The hidden power, reconceptualizing female anatomy and its systemic neglect. What if the strongest, most resilient part of the human body has been systematically ignored, misunderstood, and silenced? The female body, encompassing the abdominal core, pelvic floor musculature, and reproductive anatomy, represents an extraordinary biomechanical and physiological system capable of feats no other human structure can replicate. Yet this powerhouse remains shrouded in medical neglect, cultural taboo, and educational silence. The biomechanical marvel of female pelvic strength. The female pelvis is not merely a passive container, but an active, dynamic system of remarkable strength. During childbirth, the uterus generates contractile forces exceeding 400 newtons, equivalent to lifting approximately 90 pounds, repeatedly for hours. The pelvic floor muscles, comprising the levator ani complex and associated structures, must simultaneously provide support for abdominal organs weighing several pounds while maintaining continence and sexual function. Research published in the Journal of Biomechanics demonstrates that the female pelvic floor can generate forces of 30 to 50 newtons during maximum voluntary contraction. To contextualize this, these muscles, often no larger than the palm of your hand, support the entire weight of abdominal contents against gravity, accommodate the passage of a human being during birth, and recover their function afterward. No comparable male anatomical structure performs such diverse, demanding functions. The abdominal wall musculature in women, the rectus abdominis, transverse abdominis, and obliques, must stretch to accommodate pregnancy, expanding by up to 115% of original length, then contract back to functional capacity. Studies in the American Journal of Obstetrics and Gynecology reveal that this tissue demonstrates viscoelastic properties superior to most engineered materials, with recovery rates that would be impossible to replicate synthetically. The medical establishment's historical blindness. Despite these extraordinary capabilities, women's pelvic health remains marginalized in medical education and research. A 2019 analysis in the Journal of Women's Health found that only 34% of medical schools include dedicated pelvic floor education in their curricula. Obstetrics and gynecology residents receive an average of just 4 hours of training on pelvic floor disorders throughout their entire residency, despite these conditions affecting up to 25% of women. This educational gap reflects deeper historical biases. For centuries, medical science treated the female body as a deviation from the male norm rather than a distinct physiological system worthy of specialized study. The pelvic region, associated with reproduction and sexuality, became doubly taboo, too intimate for proper scientific inquiry, too female to warrant serious attention. The consequences are measurable and severe. Pelvic floor disorders, including urinary incontinence, pelvic organ prolapse, and chronic pelvic pain, affect 1 in 4 women over their lifetime. Yet research funding for these conditions represents less than 1% of the National Institutes of Health budget. By comparison, erectile dysfunction, affecting a smaller percentage of men, receives substantially more research attention and pharmaceutical investment. The psychological dimension, embodied shame and dissociation. The medical neglect of female pelvic health intersects with profound psychological consequences. Women are systematically taught to dissociate from their pelvic region, to view it as shameful, mysterious, or problematic rather than powerful and functional. Developmental psychology research indicates that girls receive significantly less anatomically accurate education about their bodies compared to boys. A 2018 study in the Journal of Adolescent Health found that 44% of young women could not correctly identify the vagina on an anatomical diagram, and 60% had never heard the term pelvic floor. This ignorance is not accidental, but cultivated through cultural silence and educational omission. This dissociation has measurable health impacts. Women who report higher levels of body shame and genital self-consciousness demonstrate lower rates of pelvic floor muscle awareness and control. They are less likely to seek treatment for pelvic floor disorders, more likely to experience sexual dysfunction, and report higher rates of chronic pelvic pain. The psychological disconnection from this body region creates a physiological vulnerability. Intelligence frameworks applied to somatic awareness. Contemporary psychology recognizes multiple forms of intelligence beyond traditional cognitive measures. Applying these frameworks to pelvic health reveals the systematic deprivation women experience. Anatomical intelligence quotient, or AIQ, refers to accurate knowledge of one's bodily structures and functions. Research demonstrates that women's AIQ regarding their pelvic anatomy is significantly lower than men's knowledge of their own bodies, and dramatically lower than women's knowledge of other body systems. This knowledge gap is not innate, but constructed through educational neglect. Embodied emotional quotient, or EEQ, encompasses the ability to perceive, understand, and regulate emotions as they manifest somatically in the body. The pelvic region is a primary site of emotional holding. Trauma, stress, and anxiety manifest as muscular tension, pain, and dysfunction in this area. Yet women receive virtually no education in developing pelvic EEQ, leaving them unable to interpret or respond to these somatic signals. Somatic sensory quotient, or SSQ, describes the capacity for interoceptive awareness, the ability to perceive internal bodily sensations accurately. Studies using functional MRI demonstrate that women with higher pelvic floor SSQ show greater activation in sensory cortex regions and report better pelvic health outcomes. Yet deliberate cultivation of pelvic SSQ is absent from standard health education. These intelligence frameworks reveal that women are systematically deprived of the knowledge, emotional literacy, and sensory awareness necessary to access the power of their own bodies. This deprivation is not accidental, but serves to maintain cultural control over female bodies and sexuality. The science of pelvic floor function and dysfunction. Understanding pelvic floor mechanics requires recognizing this system as an integrated neuromuscular complex, not isolated anatomy. The pelvic floor muscles work in coordination with the diaphragm, transverse abdominis, and multifidus muscles to create intra-abdominal pressure regulation, essential for core stability, continence, and force generation. Electromyographic studies demonstrate that optimal pelvic floor function requires both strength and coordination. Many women can generate adequate contractile force, but lack the neuromuscular control to coordinate these contractions with breathing, movement, and functional activities. This coordination deficit, not weakness alone, underlies many pelvic floor disorders. The concept of pelvic floor tone is frequently misunderstood. Optimal function requires not maximum tension, but appropriate variability. The ability to contract, relax, and modulate tension in response to functional demands. Chronic hypertonicity, or excessive tension, is as dysfunctional as weakness, yet this nuance is rarely communicated to women. Research in the International Urogynecology Journal reveals that pelvic floor muscle training, when properly implemented, demonstrates effectiveness rates of 60 to 70% for stress urinary incontinence and significant improvements in pelvic organ prolapse symptoms. Yet fewer than 30% of women with these conditions receive appropriate conservative treatment before surgical intervention. The silenced power, cultural and political dimensions. The neglect of female pelvic health is not merely medical oversight, but reflects broader cultural and political dynamics. Female bodies, particularly in their reproductive and sexual capacities, have historically been sites of control and regulation. Keeping women ignorant of their own bodily power serves systems of patriarchal control. Consider the language used to describe female anatomy. The vagina is described as a potential space, defined by absence rather than presence. The clitoris, with its 8,000 nerve endings and extensive internal structure, was not fully mapped in medical textbooks until 1998. the pelvic floor muscles are often described in relation to their role in male sexual pleasure during heterosexual intercourse, rather than their primary functions of support and continence. This linguistic erasure reflects and reinforces material neglect. When women lack accurate language for their anatomy, they cannot effectively communicate symptoms to healthcare providers. When their bodily experiences are unnamed and unrecognized, they are dismissed as psychological rather than physiological. The political implications extend to reproductive rights and bodily autonomy. Women who understand the strength and capability of their pelvic anatomy are better equipped to advocate for their healthcare needs, make informed decisions about childbirth and medical interventions, and resist medical coercion. Conversely, women kept ignorant of their bodily power are more vulnerable to unnecessary interventions and medical authority. Evidence-based approaches to pelvic empowerment. Reclaiming pelvic health requires multidimensional intervention addressing knowledge, physical training, and psychological reconnection. Pelvic floor muscle training, when properly taught, involves learning to identify, contract, and relax these muscles with precision. Research demonstrates that verbal instruction alone is insufficient. Up to 50% of women cannot correctly perform a pelvic floor contraction based on verbal cues alone. Effective training requires tactile feedback, either through internal palpation by a trained provider or biofeedback technology. Optimal training protocols based on systematic reviews in the Cochrane database recommend 3 sets of 8 to 12 contractions daily, holding each contraction for 6 to 8 seconds with equal relaxation time between contractions. This regimen must be maintained for at least 3 months to achieve measurable functional improvements. However, isolated pelvic floor training is insufficient. Integrated core training addressing the coordination between pelvic floor, diaphragm, and abdominal muscles produces superior outcomes. Breathing mechanics are particularly crucial. Many women habitually hold their breath or bear down during exertion, creating downward pressure on the pelvic floor rather than supportive upward lift. Psychological interventions addressing body shame, trauma, and dissociation are equally essential. Somatic therapies, including trauma-informed yoga, mindfulness-based approaches, and pelvic floor physical therapy that incorporates emotional processing, demonstrate significant improvements in both physical symptoms and psychological well-being. The role of proprioceptive training and neuromuscular re-education. Advanced pelvic health training incorporates principles of motor learning and neuroplasticity. The pelvic floor, like any neuromuscular system, requires varied, progressive challenge to develop optimal function. Proprioceptive training involves developing awareness of pelvic floor position and movement in space. This includes practicing contractions in various positions, lying, sitting, standing, and during functional movements like squatting, lifting, and walking. Research in the Journal of Physical Therapy Science demonstrates that position-varied training produces greater functional improvements than single-position training. Neuromuscular re-education addresses the coordination between pelvic floor activation and whole-body movement patterns. Many women demonstrate dysfunctional movement strategies, breath holding during exertion, excessive abdominal bracing, or compensatory patterns that increase pelvic floor strain. Correcting these patterns requires conscious practice and often professional guidance. Emerging research explores the role of visualization and mental imagery in pelvic floor training. Studies using functional MRI demonstrate that imagined pelvic floor contractions activate similar neural pathways as physical contractions. This suggests that mental practice combined with physical training may enhance neuromuscular learning. The liberation potential of pelvic literacy. Understanding pelvic anatomy and function is not merely a health intervention, but a form of liberation. When women possess accurate knowledge of their bodily capabilities, they are empowered to make informed decisions about their healthcare, sexuality, and reproductive lives. Pelvic literacy enables women to recognize dysfunction early and seek appropriate treatment. It provides language to communicate symptoms effectively to healthcare providers. It allows women to evaluate medical recommendations critically rather than accepting them passively. Moreover, pelvic awareness cultivates a sense of bodily agency and power. Women who develop strong, functional pelvic floors report not only reduced symptoms, but increased confidence, improved body image, and enhanced sexual satisfaction. The physical strength translates to psychological empowerment. This empowerment extends beyond individual health to collective action. Women who understand the systematic neglect of their pelvic health are better positioned to advocate for research funding, improved medical education, and policy changes that prioritize women's health needs. Toward a new paradigm of female embodiment, reconceptualizing the female pelvic region requires rejecting the paradigm of weakness, passivity, and pathology that has dominated medical and cultural discourse. Instead, we must recognize this system as a site of extraordinary strength, resilience, and capability. This reconceptualization has practical implications for healthcare delivery. Pelvic health should be integrated into routine preventive care, with screening for pelvic floor disorders as standard as blood pressure measurement. Pelvic floor physical therapy should be accessible and affordable, covered by insurance as a first-line treatment rather than a last resort. Educational systems must provide comprehensive, anatomically accurate information about pelvic anatomy and function beginning in childhood. Girls should learn the names and functions of their pelvic structures with the same matter-of-fact approach used for other body systems. Pelvic floor awareness and training should be incorporated into physical education curricula. Research priorities must shift to address the knowledge gaps in women's pelvic health. We need large-scale epidemiological studies on pelvic floor disorders, biomechanical research on optimal training protocols, and investigations into the psychological and social determinants of pelvic health outcomes. Conclusion: reclaiming the power within. The female pelvic region represents one of the most remarkable biomechanical systems in human anatomy, capable of generating extraordinary force, accommodating profound physiological changes, and recovering function after extreme demands. Yet this power has been systematically obscured, dismissed, and silenced through medical neglect, cultural taboo, and educational omission. The consequences of this silence are measurable in the millions of women suffering from preventable and treatable pelvic floor disorders, in the psychological burden of body shame and dissociation, and in the broader patterns of female disempowerment and bodily control. Reclaiming pelvic health requires multidimensional intervention, improving medical education and research, providing accessible evidence-based treatment, addressing psychological and cultural barriers to embodiment, and cultivating the anatomical, emotional, and sensory intelligence necessary for women to access their own bodily power. This is not merely a health issue, but a matter of justice and liberation. Every woman deserves accurate knowledge of her body, access to effective healthcare, and the opportunity to develop the strength and awareness that enable full embodiment and agency. The power has always been there, waiting to be recognized, cultivated, and claimed.